Good evening, and welcome to the newest entry in the All Florida Surgical Advocacy Series. My name is Rohan Joseph, and I am the Advocacy Committee Chair for the Florida chapter of the American College of Surgeons. Our session tonight will focus on collaboration between Florida's surgical societies. You will hear a series of presentations tonight from the American College of Obstetricians and Gynecologists, District 12, the Florida Vascular Society, the Florida Society of Anesthesiology, and the Florida Society of Ophthalmology regarding legislative priorities, recurring legislative issues, the 2021 legislative session, and opportunities to work together. Everyone is encouraged to use the Q&A feature on their screens to ask questions, which we will address during the panel discussion at the end. To start the discussion, I would like to share the 2021 Strategic Advocacy Agenda for the Florida chapter of the American College of Surgeons, which include the following. First, ensuring that scope of practice is commensurate with level of training. Second, streamlining the prior authorization process to improve access to care, particularly with time-sensitive procedures and conditions. And three, seeking an appropriation for the purchase, placement, and maintenance of bleeding control kits in schools and high-trafficked public areas at the right time. We will now hear from our colleagues on their legislative priorities. I would like to introduce our speaker from the American College of Obstetricians and Gynecologists, District 12, Dr. Andrea Friel. Dr. Friel, thank you for being with us today.
I'm Andrea Friel, and I serve as the Legislative Chair for District 12 of the American College of Obstetrics and Gynecology. The ACOG national and district legislative priorities in 2021, as well as the major issues facing our specialty on a recurring basis, includes protecting our practice in the way that we practice medicine, improving maternal health, opposing political interference in our practice, improving patient coverage, and ensuring healthcare access for all. With respect to protecting the way we practice, we're advocating for equitable payment rates for maternity as well as surgical care. ACOG strongly opposes any unfair payment cuts and is taking decisive actions to stop them from going into effect. We also would like to reduce administrative burden on the way that we practice and also advocate for medical liability reform. One of our major focuses this session includes improving maternal health. Maternal mortality prevention, we have prioritized our efforts to reduce maternal morbidity and mortality throughout our state. We still have work to do, including with substance use disorders in pregnancy, perinatal depression, and women's health research, where we would love to have the inclusion of more women, including pregnant women, in research studies about health disease and disease in women. Opposing political interference. Sound health policy overall must always be science and evidence-based so that physicians can provide patients with factual, compassionate, and individualized care and counseling. Politicians must never interfere in the patient-physician relationship or impose unjustified restrictions on medical practices. ACOG and District 12 advocate against legislation that undermines physicians' ability to practice medicine according to their professional judgment and medical training. We advocate for improving patient coverage. ACOG has a long and strong history of supporting access to healthcare for all women. OBGYNs see firsthand the devastating effect the lack of insurance can have on our patients and understand how current laws affect our practices. It is ACOG's priority to ensure women maintain the landmark patient coverage protections that were afforded to us through the Affordable Care Act, as well as have robust and meaningful family planning coverage and access, and that Medicaid and Medicare work for both women as well as the physicians. We want to ensure healthcare access for all women. No woman should be denied or limited access to quality healthcare because of where she lives, what her background is, where she's born, or where she gets her healthcare. Yet there are a number of populations that face this unique and unjust barriers, even here in the state of Florida. So we are working to advocate for policies that reduce access disparities, expand available services and providers for underserved populations, and reduce discriminatory or medically unjustified barriers to access to care. So what issues are we expecting to experience during this 2021 legislative session? Our advocacy efforts are focusing this session in the state of Florida on the pelvic exam law clarification. Many of us have had undue burden with this current law, and it is currently in the process of being clarified with the glitch bill that's in the House. We also would like support for expansion of Medicaid for 1 year postpartum. This has been done nationally, and in the state of Florida would be an outstanding addition to being able to advocate for women to reduce maternal mortality and disease in the postpartum period. So we are currently advocating to expand Medicaid for pregnant patients to 1 year postpartum. And lastly, we are continuing to advocate for equitable payment rates for maternity as well as our surgical care. ACOG strongly opposes unfair payment cuts, and we are taking decisive action on stopping this from going into effect. Currently, we did have great gains with gynecological services, but would like to make sure that our obstetrical providers are not suffering cuts with the new legislation. We would like equitable gains for both OB and GYN services as needed. So those are the advocacy focus areas for ACOG and District 12 for 2021.
Thank you so much, Dr. Friel. I would like to next introduce our speaker from the Florida Vascular Society, Dr. Palomero. Dr. Palomero, please take it away.
Thank you very much. It's an honor and a pleasure to be here, and certainly a privilege to represent the Florida Vascular Society. And in fact, I think that our organization shares many of the problems and many of the goals that have been previously enunciated. We are somewhat unique by the fact that many of our patients are over 65, and we treat an elderly and a very sick population. There was an article published this month, in fact, in the Journal of Vascular Surgery, talking about our contributions to multiple specialties. So I think the issues that I'm going to be bringing up tonight are going to be shared by just about everyone. And primarily, it has to do very much with reimbursement. There has been a 99% decline in practice revenues throughout the country. About 42% of the doctors have laid off staff, 26% have shut down their practices temporarily, and 4% closed practices indefinitely. So we need to figure out some solutions that we can all support to try to remedy these deficiencies. The one that's been, I think, alluded to earlier would be a targeted relief option, temporarily increase Medicaid for approximately 2 weeks to bring the rates for physicians up to Medicare levels. Another would be a state tax credit for physicians so that they would be able to cover increased expenses. Another that particularly is very difficult is to help patients who have temporarily lost their insurance because they're out of work to subsidize their insurance premiums. This doesn't have to be done forever, but just at least till we get through the conundrum that we're suffering right now, the pandemic. As also has been stated earlier, a state liability protection to give us some freedom from that would be specifically geared to patients so that we physicians will not be suffering some of the inequities that are shared right now. What I mean by that is that since we treat these people on a daily basis and they have lost their insurance because of the increased volumes in hospitals, they don't really have the ability to come in and get admitted. So there's been kind of a restriction. So that puts us under the gun because we are held liable since we're personally responsible for the patients. And lastly, in this note, is to eliminate insurance company barriers to care. We have all had trouble with authorizations, the prior authorizations. We need more transparency in these authorizations. We need to remove these authorizations for some of the low value drugs and services. And we need to protect the patients for their continuity of care, and lastly, and above all, stop retroactive denials. And I think that this is probably a legislative package that we can all endorse, and certainly has already been endorsed by the Florida Medical Association. Another issue which falls heavily on those of us that work with Medicare patients is the budget neutrality problem. As you may or may not remember, we had a detested issue about 3 or 4 years ago called the SGR. And when we got rid of the SGR, which was in itself bad, it was replaced by something called this budget neutrality, where there has to be whatever money is spent, you can spend more on primary care doctors, you have to spend less on specialists. And since we specialists provide the bulk, about 65% of the care, a 11% loss in income would be very difficult for a practitioner to sustain right now. So what needs to happen is that we need to figure out a way that all the doctors who are providing the care, who are going into the emergency rooms, who are taking care of COVID patients, who are going into the intensive care units, they need to be reimbursed for these services. And if they were to sustain an 11% reduction in income, that would be catastrophic, on top of the other reductions that they've already endured in their practices. We need to figure out a way to do that. Now, the American Medical Association has worked very strongly to try to stop it, but we've only gotten a 3-month reprieve. And in fact, as of December the 27th, the Consolidated Appropriations Act of 2021 was signed into law, providing a 3-month extension, which expires on March 31st. We're going to be back to square one. No one can afford an additional 11% reduction in the reimbursements. So consequently, what we need to do is, as part of the COVID-19 relief package, we need to encourage HR 315, Medicare Sequester COVID Moratorium Act, which would at least extend or stop this from happening, to make sure that physicians are adequately compensated. And what I would like to see happen, we need to all join together to ask our legislators to look at how this affects the patients, how it affects the doctors who takes care of these patients, and to rescind the Budget Neutrality Act entirely. So what I would suggest that we do is we all work together, we lobby our legislators to make sure that this does not come to pass. And lastly, what I would like to say is that while doing all of this, we have to be politically active, and you are your best lobbyist. You can contact the person who represents you in Congress, your state, your senators, and you need to be able to do this, and even maybe a small contribution, but you are by far the best lobbyist that we have. Giving a lot of money to the politician only means one thing, but if you are a constituent, this goes a heck of a lot further. So I think we need to get politically active, and this is really an important time to start. I would suggest that you join your counties and your state and your national medical associations who would work on your behest. Other speakers have talked about the scope of practice, and that certainly is important. But I think right now we're kind of fighting for survival. Insurance companies are trying to cap their payments to physicians. They impose these restrictions about authorization, and then to have the federal government come down and impose 11% reduction, I think would be pretty much intolerable. So that's where I see us as a specialty going, and that's where I see the group that you put together tonight. And I hope that we can all fight and do what we possibly can to allow us to practice independently, to allow us to render the best possible care. And the only thing I would like to say in conclusion is take really good care of your patients, because they are our best political ally. Thank you.
Thank you very much, Dr. Palomera. Next, we will hear from the Florida Society of Anesthesiologists, and representing them today is Dr. Rosemeyer. Dr. Rosemeyer, please take it away.
Well, good day. My name is Frank Rosemeyer. I'm the current president of the Florida Society of Anesthesiologists, and I appreciate the invitation for me to educate you and others on the issues which we are faced as anesthesiologists, as well as the specialty of anesthesia. Now, obviously there are national advocacy topics which are more or less dealt with by our mother organization, the American Society of Anesthesiologists, and they include things like we have already talked about, which is the MACRA level of payment with Congress. There are issues with safe care in the Veterans Affairs hospitals where they want to replace anesthesiologists with nurse anesthetist. It's a matter of also about the rule pass-through of legislation to support rurally practicing anesthesiologists. But closer to home, I want to talk about three topics which are dear to our heart, and they very much fall in line with our mission. And our mission in Florida is to have patients-centered, physician-led, safe anesthesia care. And one of the overriding topics each year and recurrent for the last 8, if not 12 years, is the drive of nurse anesthetists to become independent and therefore destroying the very much proven and safe delivery of anesthesia care through a physicians-led anesthesia healthcare model. When you look at policy, there are three things you need to look at essentially. Is it safer? Does it save me money? And does it improve access to care? Well, on the access of care issue, we demonstrably show that there is no issue with access of care to anesthesia service in the Florida state. We approached every single one of those rural access hospitals. Not only don't they provide anesthesia or surgical service, they don't require an anesthesiologist there, but the ones who do actually have an anesthesiologist on staff supervising nurse anesthetist. The second issue is that of payment. There will be no cost saving because they ought to be paid at the very same level as a physician, and that was regulated and mandated in last year's session. When it comes to safety, there's no doubt that the physician-led anesthesia care team model is by far the safest. There's not a single study which proves in any shape or form that the education, the training, the expertise, let alone the conduct of a nurse anesthetist is similar to that of a well-trained physician, anesthesiologist. So there's really, under these three big headers, no gain for the patients of Florida. And if autonomous practice, as it's currently written, proceeds in Florida, then this state is not only more unsafe, but it doesn't improve access to care, and it certainly does not have any impact on the financial situation in Florida. So for us, it is again an existential drive to lobby against this autonomous practice bill, what I call the destruction of the physician-led healthcare model. We also have another issue here in Florida with the Medicaid payment, and I'm going to have to explain to you a little bit more. Anesthesiologists are paid by time units, not by procedure. In other words, each 15 minutes we are paid an additional fee from Medicaid and other insurance carrier. Sadly, when it comes to a blend of an average of commercial rates versus Medicare, we receive 33% or 33 cents to the dollar. When it comes to Medicaid patients and the ever-growing number of patients, this goes down to 15 cents per $1 of insurance rate. So this is basically untenable in the long run, especially if we want to increase the coverage of Medicaid patients as proposed by our colleagues, but also as it is, quite frankly, the right thing to do. However, there will be an increased financial pressure on anesthesia groups, and typically what happens is that hospitals need to compensate for it and subsidize anesthesia groups. In fact, 80% of anesthesia groups statewide are in some form or the other subsidized by hospitals. 90% of anesthesia services here in the Florida are actually outsourced to managed care organizations, MCOs. And these MCOs have their own payment methodology. They have very little oversight. The overseeing agency is not an insurance commissioner by the state, but is actually the Agency for Healthcare Administration, and there are no robust guardrails. However, legislation tried to address it by FS 409-467 back in 2011, and it says that effective care management should enable plans to redirect available resources and increase compensation for physicians to a rate equal or exceeding Medicare rates for similar services. And this should happen within 2 years of continuous operations of these MCOs. And the agency, i.e. AHCA, may impose fines or sanctions on a plan that fails to meet this performance standard. Well, as is, we are not only 2 years in, we are 9 years in. This was written in 2011. And as you might have guessed, there is not a single cent more paid out by MCOs since the enaction of this act back in 9 years ago. The third issue we have is a current AHCA rule on ambulatory surgery center and pediatric surgical services with overnight stay. And in the initial rule, which was mandated by AHCA to make this, to allow ambulatory surgery centers to operate, AHCA very sensibly put in a lot of safety stop to account for the fact that pediatric patients are just not small adults. And as a patient-centered society, as a society who cares for patient safety, we very much applauded AHCA on this and tried to address some salient point in that rulemaking, and only to be shocked when we saw a subsequent version taking out almost all safety stops, so that now essentially young patients as young as 60 days old can be operated on in a surgical outpatient setting in the ACS. Doesn't depend on the ASA classification. Nobody needs to be PALS certified in that facilities. A medical director does not have to be a pediatrically trained surgical surgeon or a pediatrically trained anesthesiologist. There are about 12 safety stops AHCA suddenly took away out of the initial ruling proposal, which are now back under the pressure, I would say, of the ASC lobby. And if it would be my child, I would certainly go back to the hospital and have my child operated there. So this is totally unacceptable for the FSA, and I hope that some of our surgical colleagues will follow our suit and lobby against that. I think that sums up what the current issues are for the Florida Society of Anesthesiologists.
Thank you, Dr. Rosemeyer. And finally, we have Dr. Darby Miller, representing the Florida Society of Ophthalmology. Dr. Miller, thank you for joining us. Please take it away.
Good evening. Thank you, Dr. Joseph, so much for having me on this evening. As you said, my name is Darby Miller. I'm the immediate past president of the Florida Society of Ophthalmology, and I'm one of the legislative co-chairs right now. And the FSO is an organization of ophthalmologists across the state of Florida. It's about 500 members. We have an annual meeting every year that changes location. That's a great educational meeting for our members across the state, and actually many different states ophthalmologists come to that. We do many outreach events. It's mainly for screening for kids who maybe need a screen for amblyopia, or underserved populations who need cataract surgery, but been doing a lot of that over the years. And our final and third arm, aside from education and outreach, is advocacy. And advocacy for us is advocating on behalf of our patients primarily, and then our profession, making sure that surgery across the state of Florida is done safely, and that the providers who are conducting that surgery are properly educated, properly trained to do that surgery. Which does lead me to our current state of affairs in the state of Florida. which is our scope of practice battle. We were just informed that 2 bills were filed by Organized Optometry, one in the Senate and a companion bill in the House. So it's Senate Bill 876 and House Bill 631 that were just filed by Organized Optometry that would significantly expand their scope of practice and directly threaten the safety of patients across the state of Florida. And this would have a pretty severe impact on patient care throughout the state. Primarily, they want to perform surgery. Other parts of the bill include prescribing opioids, which we know that we're in the midst of an opioid crisis right now. And this is adding another 4,000 plus prescribers of opioids in the midst of an opioid pandemic is just baffling to us. Furthermore, allowing optometrists to perform surgery, and please, it's very important that people understand that we know that optometrists are very important to the delivery of eye care throughout the state and throughout our country. And they are very well trained as far as glasses and contact lenses, but we should not be allowing providers who are not properly educated or trained to do surgery on patients' eyes and risk them going blind. So we are partnering with many different organizations, including the FMA and hopefully other, their American College of Surgeons and other surgeons and other subspecialty societies to thwart this legislation and keep patients safe across the state. Obviously, we would ask any one of you or any one of the legislators, if you're coming into an office for an eye appointment and someone's going to be cutting on your eyes, who would you rather have doing that? A medical doctor with at least 4 years of residency training and usually 1 to 2 years of fellowship training. So at least, 10 years of training there and about 20,000 hours of training and residency on surgery versus an optometrist who has not attended medical school, has not done a residency training program, and has probably taken a week or long weekend course on how to perform surgery on patients' eyes. So we thank you all very much for listening and for your time this evening, and we certainly would appreciate any help that you guys could provide, and speaking out to your legislators, emailing them, calling them, just letting them know that both House Bill 631 and Senate Bill 876 are not good for patient safety across the state of Florida. Again, thanks so much for having me this evening, and I look forward to working with you all to keep patients safe across the state. Good evening.
Thank you very much for joining us today and participating. I want to say thank you to all our presenters for being with us and sharing the perspectives and the important advocacy issues that are pressing to each society. There's obviously a common thread that runs through all our societies. And my first question will be for the group. How, as societies in Florida, can we support one another during the Florida legislative session? Dr. Miller, with what sounds like a pressing scope of practice issue facing ophthalmology, I will go to you first.
Great. Thank you, Dr. Joseph. Thank you all again for allowing us to join in this conversation. So from an ophthalmology standpoint, I think standing with a united voice seems to be the most important thing that we can do as surgeons and physicians. Standing, for patient safety for our profession, I think would be the best thing we could do. 2017 was really a perfect example for us. We had a scope bill that was filed that year, and we had, spokesmen from American College of Surgeons, the FMA, ACOG, and other specialties come to Tallahassee and testify on our behalf, advocate on our behalf, contact legislators, and speaking with that unified voice really helped us thwart that legislation. We hope to do the same thing this coming year. I think, we remember the words of Ben Franklin, which is, we must all hang together collectively as a group, or we will hang separately as individuals. So hopefully we can stand up together and hang together on this issue.
Well said. And I'd like to go to Dr. Rosemeyer. Your perspective on the scope of practice. Obviously, this is not a new issue. It's been going on year after year. Are you all doing anything slightly different with the strategy for this year?
Good evening. No, there's nothing new in this. We are battling this for the last 12 years. We were successful so far. Sadly, last year, the legislature under Speaker Oliver decided that it is a good idea to allow primary care nursing staff to be independent now, with really no influence on the access of care costs or anything else in the state of Florida. So we have the same approach every year. We are educating our legislators. Sadly, there is sort of a high turnover in the House. There's also some turnover in the Senate. So it's a little bit of a deja vu and Groundhog Day with our arguments. The arguments have not changed. It is neither cost effective nor safe, nor will it improve access. And we are deploying our own members to see their individual lawmakers. It is very powerful for a doctor to educate basically what are non-physicians and non-medically trained persons on the issues and why it is such a bad idea and why it puts the health of the Floridian population at risk. So this is again, it's an existential issue, not only for us, but for every physician here in Florida, but also nationwide. It's sadly a trend which sort of permeates like a cancer throughout various states with some success for APINs in some stage, but we hope that Florida will again stay put and does not allow any further destruction of the healthcare team. We are doing our part. We are meeting with legislators both via Zoom. Obviously in the old years before COVID, we were in the offices. We are presenting our case for the specialty of anesthesia. Those are the data we have. And so far this approach has worked, and we hope that it works again.
Thank you, Dr. Rosemeyer. Dr. Palomero, any thoughts?
Yes, thank you, Dr. Rohan. I have two thoughts. The first is that the doctor is the best lobbyist. Every one of these legislators in the state of Florida has a doctor, and you have the opportunity to interact with that doctor, with the elected politician, and you have the chance to convince them in a very neutral setting of the legitimacy of your position. And that is highly, highly effective. As I said in my other remarks, that doctors are the best lobbyists. Number two, as a person who has worked with the county and the state medical societies for 40 years now, and having worked with the Florida Medical Association specifically, they have a very aggressive political program. And I would encourage everyone on this call and all of the constituent members to make sure that they are members of the Florida Medical Association and participate. You need a really big tent to be able to pass legislation and to protect adverse issues from becoming law. And the more that we work with the Florida Medical Association and work with them to define our issues, to lobby our issues, and to intercede with the legislators, the more successful we will be. So I think I have to give Brian credit for putting this together tonight, because we are all facing the same adversity. And the more that we work together, the more that we use our political strength and the justification of our position to protect patients, the more successful we will be. Thank you.
Thank you, Dr. Palomero. Dr. Friel?
Sure, just, I can't echo enough the comments that have already been said, but keeping the patient first and the fact that the safest care to them certainly is in the hands of physicians, and being positive about that, as well as just making sure that we're all working together, our lobbyists, and also working with the FMA. We commonly do put all of our cards together in a basket, whether working in opposition or support with other with each other in our specialty societies. But our lobbyists do meet with the FMA every Monday. So making sure the members of our organizations also have access to us as our advocates to also inform the lobbyists so that we stay informed and on the same page and working together. But being involved with making sure that our lobbyists, continue to work together. They operate step with each other and meeting with the FMA to make sure our goals are expressed to the legislators.
Thank you, Dr. Friel. Just reading some of the comments in the chat feature, there was a comment from Dr. Redan for people to be engaged with the hospital lobby. I think that's definitely a good thing to do. There was also a question from Dr. Daubertine. What are the actionable items we can do together? Obviously, scope is a big one. If you don't mind, Dr. Friel, what are your thoughts in terms of things we can work together and how we can work together? And I'll just run down the panel.
Sure, just using past experiences and working together is one. For instance, obstetrics and gynecology have worked with scope of practice with the battle with CNMs nationally as well as locally, licensed, which we consider lay midwives versus the independent practice of CNMs. Just how we can come together and work from past experience on what works and what doesn't work. And that, that's pretty much the main focus of where we were going.
Okay, thank you. Dr. Palomero.
Yes, sir. There are several issues that need to be addressed. And the one, as I pointed out in my prepared comments, was the budget neutrality and the potential 11% reduction in income. And that is going to be devastating. The American Medical Association is working on this to try to extend this by making it part of HR Bill 315, Medicare Sequester COVID Moratorium Act. I think if it's passed in there, it would protect us. But I think we need to work collaboratively with the American Medical Association and each individual too. Everybody has a congressperson in their district and you need to call them. Some of us take care of those people and you need to call them and make sure that this would be devastating to the independent practice of medicine. And then number two, as was pointed out in some of the other prepared comments, what we need to do is to temporarily increase Medicaid to Medicare levels. I mean, those are things that are actionable, and I think we have the public sympathy, and I think we would have the legislative sympathy on our side also. Of course, the insurance companies who are not our friends, with the authorizations of removing the prior authorizations for low-value services and drugs, require transparency, and to stop the damned retroactive denials. Those are very, I think, actionable issues that we can take up and we can work collaboratively on. I'd like to make one comment since they have the floor right now. Working with the hospital association, Florida Hospital Association, may be difficult. They have their own agenda, particularly the proprietary hospitals. I don't know how far we can go with them. As a person who, we worked together with them when we reformed liability in early 2000s, if we share an issue, we can work with them. But unfortunately, I think they have some of their own perspectives and their own objectives. And I'm not sure that they think too highly of physicians. So I think we need to be careful. Again, we walk down the road as far as we possibly can. And if we have to divert, we divert. Thank you for the opportunity of presenting my views.
Agree, and that's actually a good point because, one of the sessions that the Florida ACS had planned was a session to include the Florida Hospital Association and some other big corporations, and it was hard. It was hard to, it was hard to get them to be speakers for a talk like we're having right now, and I think that also speaks to the differences in agenda. And their arm is big and very well funded, and they may not want to give out certain piece of information which could potentially be turned to be used against them.
Correct.
Okay, Dr. Rosemeyer.
Well, I mean, probably my answer is as follows. It is very easy to go behind, for everybody's go behind scope of practice. And because that is a universal issue for all of us, the the sort of ill-defined, ill-conceived idea that a mid-level provider can basically substitute a full-fledged trained physician. I think that's a no-brainer for all of us to get behind. The trouble I see is that other issues are very specialty specific. And while there may be some overlap with, for example, the ARCA rule on pediatric overnight stay for ambulatory surgery center with the Surgical Society, frankly, I don't understand and I don't know the issues I can bring forward in support of other societies' goal. And we have to be cognizant that a politician has only so much time for a particular topic and for a particular visit. And I find it then very difficult to dilute the message from my society, and I would find it similar to your society, to then really touch other topics other than a cursory mentioning that, for example, the Florida chapter of the ACS wants to bring the blood bleeding kit into schools and traffics, which is very commendable. But there's very little more I can see, or I find it difficult to really have the mechanism to now promote this even more than just a cursory mentioning with a lawmaker. So if you can give me ideas how I can incorporate your agenda into mine without diluting the very same reason I'm there in the first place, I would be more than happy to entertain that.
Thank you. No, it's a valid point. I mean, there are times when our interests overlap and then they diverge sometimes. Yeah, I agree. Dr. Miller.
Yeah, and I'm just to speak on that point a little bit longer, I guess. I saw John Armstrong's comment about bundling advocacy efforts, and I think that's probably where the FMA does come into play, so that each of us, through the FMA would know what each society or what specialty society interests are or needs are. But, the pressing issues that we have that are, I guess we've talked about, reimbursement and patient safety, scope of practice, simply just contacting your legislator. If people even on this call are listening and they heard me talk about Senate Bill 876, House Bill 631, just please tell your representative, your senator, your state representative that you stand for patient safety and that we shouldn't be allowing optometrists who are not properly trained in surgery, not educated properly, to be performing surgery or prescribing opioids at this juncture. So,
thank you. Do any of the other panelists have any thoughts about the question by Dr. Armstrong about bundling advocacy across our specialties? Because I think what happens is the APRNs kind of almost turn that back against us and make it harder for us to make the argument, because they kind of branch out a little bit and say, oh, we're going to be focused just on this area and this area. And the thing about their practice is they can switch from practice to practice every 2 or 3 years, whether they like it or not. And any thoughts on bundling this across specialties?
Yes, the APRNs are a group that is very politically ambitious, and I think while they provide a certain service in underserved areas, by the same token, they're trying to do more than they are qualified to do is certainly a detriment to the care of the patient. It works best when they work with all of us. So that is an objective that we all share. And I don't see why we cannot all jump on that bandwagon and continue to pound on that drum. And number two, concerning anesthesia, I'm a vascular surgeon. All of my patients are sick. They are at least an ASA 3, if not more. and I lose a lot of blood in most of my operations. And quite frankly, my success correlates directly with the skill of the anesthesiologist. And I would be sure to trumpet your horn and to do what I possibly can to say that anesthesiologists need to be supported. We need to have the best, most qualified anesthesia provider in the room. Otherwise, I'm going to suffer, the patient's going to suffer, the anesthesiologist is going to suffer, and we are not going to be achieving our enunciated goals. So I think most of us that are on this call, anesthesiologists, service the OBGYNs, they serve the, maybe to some degree, the ophthalmologists, they serve the American College of Surgeons. And I don't think any of us would want to be in there, let's say with a shocky patient who has a, let's say, an acute cholecystitis, who has a perforated diverticulum or some other life-threatening emergency without a good anesthesiologist. So I don't think you're really on that island by yourself. I think you can enjoy all of our support, and I'd be more than happy to verbalize my support for your specialty.
Agree. And I think that's definitely, I think it would be fair to say it's a common sentiment for all of us when we're facing scope of practice. But I have a comment to Dr. Armstrong's question, and I'm reading from my email, a comment from our lobbyist, Chris Newland, with regards to telehealth. And he said there appears to be a consensus that telehealth has worked well during the pandemic, and seven different bills have been filed to allow increased prescribing and telephone calls. I expect these to ultimately be combined into a single piece of legislation. You know, one of the arguments that the APRNs and mid-levels have made have been access to care. And I think we can make the argument that access to care is not as big an issue if we have telehealth. And I think one way, and obviously this is a little different from CRNAs because you're going to be in the operating room, but for a lot of the other specialties, you could make the argument that having access to telehealth would definitely reduce the issue of access to care and possibly be a way to bundle, you know, restricting scope for a lot of the specialties. It's just a thought. And I just want to share a comment from Dr. Chase. Don't forget to oppose the provision to allow out-of-state telehealth physicians to supervise APRNs and PAs in state. That's in Senate Bill 864. Thank you, Dr. Chase. Okay. I'm screening through the questions. You know, I think this is something we need to talk about as doctors and as societies. We don't talk about it enough. This is to the panel, and please feel free to add comments to the chat function. What is the importance of the PAC for your society? Let's start with Dr. Miller and then run down Dr. Friel, did I see you raise your hand?
I'm happy to talk about the importance of the PAC because just, you know, it especially with our lobbyists, it's what people don't understand is using the PAC is how you gain access to your legislators. So the biggest PAC donations and the biggest support, whether it doesn't always have to be the biggest dollar amounts, but it has to be the amount of people that are actually donating to the PAC in addition to the dollar amounts, gives you access because it shows that, you know, that they need to listen to us. It helps the lobbyists in their efforts. So it's not really buying votes we need to dispel all of those myths, but that the PACs are really there to help us gain access so that we can have conversation about this legislative efforts. And in addition to that, when they listen to us, Dr. Palomari is correct. We are the best advocates for physicians, and we can't get in the door for them to listen to us if we don't have a strong PAC. So,
thank you. And Dr. Friel, any tips or advice that you can share that the ACOG uses to, you know, to encourage members to contribute to the PAC?
Sure, we kind of, competition is always great, but then usually at our meetings or through giving them ideas of when to give and how to give. So for instance, you can approach a group and tell them, you know what, so that you don't even see the money, take $50 out of your check every month and put it in the PAC fund. So I started in 2001 at North Florida Women's Care, and we literally, I still have a PAC fund, and if I don't use it by the end of the year, shame on me. use it for Christmas, but just kind of taking that money to the side. And so that you know that when it's time to give, because we basically have about 5 months, including the weeks of the committee hearings and the 9 weeks of this session, to get the greatest support for legislation on the bills filed. And so you really need to have your money available. It's always nice to have someone physically there to give a check at times. So using those PAC accounts, making sure you have individuals as well as the groups doing their, keeping PAC accounts separate, kind of money you don't really see, but it goes for a good cause.
Thank you. I know there is another big practice in town, in Tallahassee Orthopedic Clinic. It's a big it's a big provider of orthopedic care in Tallahassee, and all the surgeons in the group have a PAC fund. Yep. And Dr. Borum, who's one of the active surgeons in Tallahassee, also on the FMA, he kind of, spearheads that mission. And each one puts away some money, I think, per month. And at the end of the year or 6 months, that money is donated wherever you want. And like Dr. Friel said, if you don't, shame on you.
We also teach our junior fellows and just get them really early. We have encourage participation, basically showing people how to give and then show them how their money's used. And that's where transparency comes in. So the legislative chairs have to do a good job working with their lobbyists to show our constituents that we're working together and what their money's going for.
Thank you. Any of the other panelists? Yes, sir. Go, please.
I just saw Dr. Dobertein's comment, and he's absolutely right. At the risk of losing my membership in the Florida Medical Association, I think we are living in the post-PAC world because some of the Senate races that have been going on nationally have raised obscene amounts of money. And what we've learned here, what I've learned, I'm still the chair of the PAC in Broward County, actually. What we've learned is giving money locally to politicians has a tremendous effect. Particularly, we interview all these candidates every 2 years in our cycle. We give them money, we individually give them money, and that has been remarkably successful, remarkably successful. Me sending a check for $500, let's say, to some guy in Jacksonville is not going to have the same impact as me giving a $500 check to somebody locally. As Mark said, we're kind of all burnt out with giving money. And if the information from the Florida Medical Association would indicate that the Florida Hospital Association has tons of more money than the Florida Medical Association has. And yet we are probably one of the second or third largest PACs in the state. I'm not saying that we should not do that because that has its own effect. It's nice to walk in with a check for $10,000 to somebody. But however, we're kind of living in the post-PAC world. We've had such polarization of our politics for the past 4 years that I'm not sure that we have the same voice that we had, let's say, in 2015. That's a question, not really a statement. So I'm saying that money given locally and you handing a check personally to your legislature and telling them what your goals are, I think it's far more effective. And I would also like to point out in conclusion that when we changed the tort laws in the state of Florida in 2002, 2003, and 2004, we were outspent by the trial bar approximately 20-4. I think it was a ratio, something like that. I think we spent $4 million. And Matt Crowley, I think, could probably attest to that to give the exact figures. They spent over 20 and we still won. We still passed a constitutional amendment and we still changed the laws in the state of Florida, which to some degree are still working. So I still hold out that you are the best lobbyist. You handing your representative or your senator a check for $500 has a lot more impact than doing it elsewhere.
Thank you, Dr. Palomero. Dr. Miller and Dr. Rosemar, any?
Yeah, I've got a couple of comments. Yeah, I can echo Dr. Palomero's notion there. We are fortunate in the FSA that we have a very strong PAC. It's probably the best funded outside the FMA and maybe outside the ophthalmologist, if I'm correct. But more importantly, it is the superb effort by our lobbyists and essentially tagging every single check we get out with a personal meeting. And this is much easier now with a Zoom meeting than it was. So I thought that the Zoom meeting, the personal meeting was actually a hindrance in years past, but we found that it's much easier to schedule a Zoom meetings, a half-an-hour meeting with the legislators in this pandemic than it was ever before. So really no substantial amount of money is handed out and distributed without an anesthesiologist, especially a local anesthesiologist, then supported by one of our executive members and meet with that legislators. So it is important. We have about 30% of our organized members within the FSAs contribute to the national organization. 33%. Our national organization, in comparison to other states, we are like in second and third place always. And sadly, only about 20% of our local physicians contribute to the Florida Society of Anesthesiologists PAC. So one of my things as a president is trying to move these numbers around, because it's really local politics, as Dr. Palamera pointed out. There are important issues on the national side, but my mother organization will not miss $50,000, and we would very much appreciate $50,000 more in our PAC. So this money is influential. It doesn't change opinions, but it gives access, and it gives us an opportunity to make our points, to bring them across, because otherwise that void is filled by somebody else. So we find that very, very important. We have lots of resources available, how we get to members and update them regularly. We are going to have sort of local advocacy meetings now planned for this year, and obviously scope practice and CNAs, independent practice is always a good money maker for us. So that's where we stand. We support that. We are also supporting the FMA. All our FMA delegates are in the 1,000 club, and we are spreading the word that there is very much value in belonging to both. Yes, it is a lot of money, but at the end of the day, it's probably 1% of each other salary cent. And we are trying to make the point that this is really important.
Thank you. And we're kind of coming close to concluding. Dr. Miller, any last parting thoughts?
No, I just echo what people have said. I think it's a both and approach. I think you have to be giving money to these PACs, and I echo what others have said. You know, we're contributing to the FMA PAC, to our own individual societies PAC. So we're also going out to meet these legislators and giving them a check. And I would say, you know, the biggest thing is getting to know the legislators ahead of time before you have an emergency or a scope bill is on the floor. You know, it pays to know your legislators, to get to know them, know that you are a resource to them also. So if they have medical questions, they know they can ask somebody who's trustworthy. So yeah.
Thank you. And we'll take one last question from the participants. Dr. Radan asks, any thoughts from the panelists on how to get the word out to a large number of docs who don't participate in advocacy? And there's one more. Okay, so the last one was a comment. The outcomes in Tally last year were a disaster. Hard to ask colleagues to jump on board who are novices in the advocacy realm, and we lose like that. True, all true. So any parting thoughts for Dr. Radan's question and how to get the word out to our colleagues who are not participating?
So we have an initiative, if I may take this question, within the FSA to identify a large group which are not yet organized and not contribute in any shape or form to political or professional advocacy. And we want to reach out to them personally with named FSA executive members and try to get a foot in the door to make our value statement as an organization. Now, with regards to Dr. Dabatin's comment, that is well taken. However, what we as a specialty or what we as in medicine sadly don't do properly is to inform our members of all those crazy bills which we actually successfully defeated. They never make the surface. For example, last year it could have been much worse. Last year could have been seen that there's a universal APIN bill out, not only one for primary care. So I think we are sadly for years have selling ourselves short in, number one, not really advocating our successes, because maybe it's just us physicians. We are just humble people. We don't need that big social media thing like the APINs do, and we know who we are, but we're doing ourselves a disservice by not sort of informing our members and the public like what was defeated and which win we had in Tallahassee. And that makes it difficult, especially for somebody who is new to advocacy, who only sees like a single bill and doesn't know the process which it took to defeat other bills, or why this bill now actually came through. So I think there has to be something to be done on the PR sector to improve that.
I agree. And just a comment, Dr. Daubertine was the one who actually got me involved in advocacy. So Dr. Daubertine, I mean, obviously you've been doing this so much longer than I have. And all I can say is, keep doing everything that you're doing. I'm here in advocacy because of you. And I'm sure that as you keep reaching out to, young fellows in the Florida chapter and, across the state, you'll find more people than you realize who are going to get engaged and keep staying engaged. So having said that, I wanted to thank a few people. A big thank you to Brian Hart, our executive director, for recording all our presentations on Tuesday, putting this presentation together, coordinating everything. Brian, a big thank you to you from myself personally and Florida chapter, as well as all the other societies that were represented here today. My sincere thank you to Dr. Miller from the Florida Society of Ophthalmology, Dr. Fryal from ACOG District 12, Dr. Rosemeyer from the Florida Society of Anesthesiologists, and Dr. Palomar from Florida Vascular Society. Thank you from the bottom of my heart for being here today. Thank you to all our participants for tuning in and having a robust discussion. And I just have 3 comments as a closing remark. One is something that I learned last year: advocacy is a marathon. It's not a 100-meter dash. The second is relationships is really the foundation for advocacy, with our legislature, with our colleagues. Getting grassroots advocacy structured and set up is huge. And lastly, when people say it's not about the money, it's about the money. So stay active in your PAC, in your society, the FMA, AMA, and your specialty society. So with that, a big thank you to everyone who joined in and our participants, and Brian. Thank you all very, very much. Have a good night, and we'll hope to see each other soon in the future.